I hope everyone can see the, so Kusumji, yes, please.
Namaste, everyone. Namaste, everyone. I'm Kusumlata Tiwari. I'm a first-year PhD student now at the Central Department of Anthropology here at your university. So I'll start the presentation now. Aloha and good morning from Nepal. First, we'd like to thank the organizer of the symposium for providing us the opportunity to share our research work. We also like to acknowledge all the health care workers who voluntarily participated in our research and shared with us their painful but encouraging stories and experience of stigmatization they have faced during the beginning of the pandemic in Nepal. Thank you all. In our presentation, we highlight and discuss the different forms of stigmatization experienced by the nurse and other healthcare workers during the based on the study we undertook for UN agency based in Nepal during October to December in 2020. When Nepal was still under partial lockdown due to the first document the form of stigmatization and discriminations faced by the various groups, which included COVID patients and their families, returnees, migrants, healthcare workers, street vendors, and recycle or Tiwari collectors from Madhesi community in Kathmandu city, Muslims and Dalit community from different districts. But here in the presentation, we only focus on the study findings on the stigmatization experienced by the healthcare workers. This one. For documenting the experience of healthcare workers, we conducted telephone as well as in-person interview and focus group discussion in November 2020. We phone interviewed 12 nurses, including auxiliary nursing midwife from 9 districts. Similarly, we conducted in-person interview with 1 doctor and 1 lab technician in Go Rohtahar district, and 1 focus group discussion with a group of health workers in Jhapa district. Well, if you look at the background of the pandemic, scholars of the history of disease and epidemics have demonstrated that every pandemic in the past lead to various form of stigmatization and discrimination against some group of people. With historical evidences, they argue that when epidemics strike, impacting more population and territories, people also tend to find scapegoats to blame for the spread of the virus. The COVID was no exception. We all know that. According to WHO, with the outbreak of COVID-19, stigma related to disease were reported from different parts of the globe. The fear, anxiety, misinformation, rumors, and instant circulation of the rumors and fake news exaggerated the stigmatization against some specific groups. For example, returnees, migrants, Muslims in India, Asian Americans in US, and so on. The healthcare workers, who were one of the most important frontline workers in treating COVID patients and controlling the spread of the virus, also became target of stigmatization, social boycott, and even physical violence because they were considered as a potential virus carrier and threat to others. Such stigmatization and even violence against healthcare workers also surged in Nepal, particularly during the early period of the first wave. When asked if healthcare workers face any stigmatization in her area, in rural municipality located in Dalit district in far western Nepal, an assistant nurse of local government health center told us over phone in November that before the COVID, villagers wanted to be close to the doctors and nurses by making efforts to connect with us. But now when we go to the village, local avoided and stay away from us. They are frightened that we could be infected and that we are bringing the virus to their place. The way she pointed out the reversal of people, social acceptance, and responsibility towards healthcare workers during the early period of pandemic powerfully captures their shared experience of stigmatization and social boycott. She also underlines how local people avoided avoidance and fear of healthcare workers impacted the timely delivery of other services such as immunization of infant babies and mental health care, etc. All the so all the healthcare workers we interview confirmed that they had faced some form of stigmatization and social avoidance during the early period of the pandemic. They also told us that such stigma had decreased over the month as the COVID cases increased and people's sense of fear, threat, and uncertainty decreased. But even during the time of our research, that is from October to December 2020, some form of stigmatization of healthcare workers continue to persist. For this, we will briefly provide the overview of the patterns of stigmatization experienced by, here you can see this, these are the pattern of stigmatization experienced by the healthcare workers we interview for this study. The first one I would like to talk about is stigmatization by one's co-workers, the colleagues working in the same hospital. During the early period of the pandemic, doctors, nurses, and lab technicians who have worked in the COVID ward had faced some form of avoidance and stigmatization from their own colleague in their hospitals. For instance, a doctor from Gaur Hospital told us, I faced many rejections from my own colleague in the hospital. Fearing the spread of the infection, they hesitate to talk to me and avoid having tea with me. The lab assistants from the same hospital in Gaur had a similar experience. He remembered some colleague in the hospital hesitated to speak to me. Some even shifted their duty hours from mine, thinking that it was not safe to share their duty with me. On the top of this, the community people threatened the lab assistant's family not to bring him home. He lived in a hospital residence for 3 months away from his family. Similarly, a nurse from Birganj Parsa also shared over the phone and told us our colleague in the hospital did not allow us to walk the path that crosses their ward. They fear even talking to us. They made gossips about us. The finding suggests that during the early period of the pandemic, even healthcare professionals treated their colleague directly involved in the treatment of COVID patients as scapegoats and possible contagious bodies. So I'd like to stop here. Thank you. Now, Dr. Janak Rai will lead this over to you, sir.
Thank you, Kusum. Let me quickly go back there. Now, I will highlight on our findings, particularly on how differential forms of stigmatizations were experienced by healthcare workers, depending on their social backgrounds, whether one was living in their own houses or in a rented rooms, or what we call in Nepali dera, or whether one was a local resident or an outsider, or even one's ethnicity, such as a Madesi identity, all interface to produce differential level of stigmatization. All nurses living in the rented rooms and apartments in Kathmandu had faced, and some continue to face, pressure from the house owners not to stay in their rooms. The pandemic had exposed the unequal power relation between the tenants and the house owners. In the absence of legal provisions protecting the rights of the tenants, many who come from outside the Kathmandu, the pandemic enabled, we argue, the house owners to exercise surveillance power over the tenants. They could even evict the tenants in the pretext of threats from the disease. And we'd like to emphasize that these issues of health workers living in rented apartment does have a relationship with public health performance during a period of a public health crisis, and this issue has not received the kind of attention that needs to be focused by scholars and others alike. The experience of a young nurse working in the government COVID hospital in Kathmandu is a very illustrative example of such stigmatization. We'll call her Miss S. At the time of our study, Miss S was COVID nurse in the intensive care unit. She comes from the far eastern Tarai regions and lives in the rented apartment with her younger sister in Kirtipur area. the same area where we're speaking right now, from where we're speaking right now. Her sister left for the village just before the first lockdown in March 2008. After my sister left, I began to feel very lonely when I used to come back to room. After the long and tiring work hours in the hospital, she would recall over the phone interview. Then the house owners began pressuring her not to come to the room and stay in the hospital. Her neighbors who live in the other rooms in the building began to treat her as a potential virus carrier. They began avoiding her and stopped even talking to her. In the beginning of the pandemic, Ms. S felt very lonely, isolated, unwanted whenever she came back to her room. She told us, each night I would cry. I could not sleep. I developed anxiety. I would call my parents who would console me and encourage me to be strong. After 2 months, she started to live in a local hotel room provided by the hospital. Once or twice a month, she kept visiting her room to check if her things were safe and sound. But the landlord still insisted that she should not come to the building because his daughter has an infant baby and they would not like to get infected by her. Subtle forms of stigmatization and discrimination against healthcare workers, particularly those who live in the Dera, had persisted during the time of research in Kathmandu. In comparison to the nurse just we talk about, a nurse from Jhapa, a district in lowlands, had a bit differential, had different experiences. She works in a private hospital. She is a local and lives with her parents. She generally rides on a public vehicles to and back from the hospital. During the early time of a pandemic, sometimes the driver and other passengers would ask her not to ride the vehicle if she were a nurse. They would politely say this, but it still used to hurt me to know that people treated me differently because I was a nurse, she told us. In some cases, nurses from particular ethnic background face severe stigmatizations and discrimination because of the grammar of identity that already brackets them as outsiders and others. This is exemplified by the experiences of a Madesi nurse who worked in a COVID hospital in the Limbuli province and lived in a neighborhood primarily dominated by the hill people. When she and her husband tested positive for the COVID, the community saw the entire family members and blamed her for bringing the virus to the community. They were even not allowed to open windows and dry their clothes in the balcony. Sobbing during the interview, she said, "It was a horrible time. More than the virus, the people's attitude and behaviors toward us was painful and disturbing. I had never imagined before I had to face such a situation because of my profession. I understand that people were worried and concerned, but the ways they treated us were something unthinkable and heinous. Well, now things have changed. People say, 'Sister, would you donate your plasma when I get sick?' They would ask me for help." These experiences of the healthcare workers who spoke to us show that they face more stigmatizations in the workplace, community, and in the residence they live during the early period of the pandemic. Our study was based on a small number of healthcare workers. Hence, we do not claim that our findings can be generalized. However, the study was undertaken during the partial lockdowns when some specific social groups such as COVID patients and their families, returnees, migrant workers, healthcare workers, Muslim, Dalits, street vendors, and others, working class people, continue to face different forms of stigmatization and discrimination. The Nepali media carried out news articles on stigmatization of healthcare workers in particular. The government also asked people not to discriminate the healthcare workers and even requested people to appreciate people to light candles in recognitions of their contributions and their important role. However, such rhetoric of national recognitions and celebration did not necessarily translate into concrete actions and results. For instance, nurses living in the rented rooms were facing pressure from the house owners during the period of this study, our study, that is 8 months after the first lockdown. And similarly, healthcare workers who had tested positive were continue to be socially blocked in areas such as in Dalit and other places that we have studied. All the healthcare workers, 5 minutes noted, thank you. All the healthcare workers we interviewed did not receive any support from the local government authorities and administration regarding the stigmatization and discrimination. We were told that the hospital management and their units were preoccupied with treating the COVID patients. The issues of their stigmatization and discrimination did not receive any concrete institutional concern, discussions, and support. Healthcare workers share their experience with one another, with their peers and colleagues. In many cases, hospitals provided nurses with accommodations and food and informed them of the availability of counseling doctors. During the early period of the COVID spread, the government asked the house owners to report or check if any newer outsiders had come to live in their apartment. Even the local government circulated posters and pamphlets that said outsiders were prohibited. Such politics of boundary making between inside and outsiders not only reinforced the idea that people living in the rented room as outsiders, but it also accorded more power to the household owners over their tenants. That led to the stigmatizations, that also led to the stigmatizations of healthcare workers. There is still lacks an in-depth study of the experience of COVID-led stigmatization and discrimination in Nepal. Ours was a short-term study. However, by focusing on the experiential narratives of the healthcare workers, our studies have shown how confusion, anxiety, and fear interface with pre-existing structural forms and relation of inequalities, dynamics of powers, and marginality to trigger differential stigma and discrimination against certain groups, gender, class, and professionals. Thank you very much.
Thank you very much, Janak and team. Does anybody have any questions, quick clarifying questions that they would like to have answered before we move on to the next panel? No, okay, then we'll just keep moving right along. And if you have any larger questions, you can just say, or anything that comes up as we keep going, you can just save them for the Q&A section at the end. So our next panelist is Sadhana Paudel from Tribhuvan University in Nepal, with experience of women health professionals working in the front line, personal reflection. So Sadhana, if you want to take it away.
Thank you, Kathleen. I will just share my screen. Hello and namaste everyone. I am Sadhana Paudel, professionally a clinical nurse and PhD scholar from Gender Studies in Tribhuvan University, Kathmandu, Nepal. Today here I am going to present my own personal experience titled Experience of Women Health Professionals Working in the Frontline, Personal Reflection, a case from Tribhuvan University Teaching Hospital, Kathmandu, Nepal. Here my experience can offer the unique experiences, although it cannot be generalized. The experiences of women are trivialized, distorted, and are suppressed. So it is important to bring the experiences of women. Subjective experiences brings the facts and explores the discrimination and subordination faced by women, because women experiences had to be kept at the center. Now, I will be discussing throughout the presentation, I will be discussing about the background of my hospital, infographic data of COVID-19 cases, working modality and incentives, challenges faced by hospital management and workers, challenges faced by as a woman frontliner, profession and my family, a COVID case where my mind stopped, getting infected and quarantined, learning and hopes. Here talking about the Tribhuvan University Teaching Hospital. It is a semi-governmental hospital affiliated to TU, Tribhuvan University. And there I worked on COVID from 20th August 2020 to 12th February 2022. It is 1,000 bedded hospital and renowned for multiple super specialty department service at reasonable price. It is a referral center too. At the first period of COVID flow, the teaching hospital was not announced to be a dedicated hospital because keeping at the center of its multiple specialized services, COVID hospital was dedicated to other hospitals. At first, it was not dedicated to COVID, but when the first case on 13th May 2020 observed in Tribhuvan University Teaching Hospital, then TUTH cannot refer the cases to other hospital and the admission was started. During the first flow of COVID, TUTH had allocated a different building separated from main building where ortho and ENT department used to give services. At that time, emergency isolation ward and ICU for COVID was started on the building. Personal protective equipment, including N95 and surgical masks, ear caps, boots, shoes cover, hazmat suit, gowns were made available to the TUTS from government of Nepal and through international donations too. At that time, cases were divided into mild, moderate, and severe. The bed charge for mild was 3,500 per day, for 7,000 for moderate ones, and 15,000 for severe cases. Severe cases used to admitted on ICUs, and mild and moderate cases were to be admitted on general wards. This charge had been provided by the government, excluding other investigations and medicines. Also, had been provided by the government of Nepal. During the COVID-19, in the first flow, the minimum admission per day was 1 and maximum admission per day was 121. During the second flow, it was 2 minimum admission per day and 388 maximum admission per day. Similarly, on third flow, the minimum admission per day was 1 and the maximum admission per day was 228. Till date, in TUTS, 3,782 patients had been admitted. During the period of first, second, and third flow, I had worked on first flow on respiratory ward, 30 general beds. And in second floor, I worked on the same respiratory ward where 18 were general beds and 10 beds were allocated for high dependency unit. And in the third floor, I worked on the oncology ward. The capacity of the ward was 30 beds, but due to lack of human resource, the ward was extended up to 40 beds. While talking about the working modality and incentives, before COVID and on non-COVID wards, the normal shift was of 8 hours in daytime and night shift of 12 hours. But to minimize the exposure to in the COVID wards, the working hour was increased up to 12 hours per day. Day shift from 8 a.m. to 8 p.m. and night shift from 8 p.m. to 8 a.m. in COVID ward for continuously for 1 week. At the previous period of first flow, 2 weeks of quarantine was provided to the COVID workers. The first week for hotel quarantine, followed by the compulsory PCR test, and the second week for the home quarantine if get negative to PCR test. If unluckily someone who got positive for the PCR test, then there was option for the staff. Either they can go home quarantine or they can also be admitted in the hospital because there was social stigma. People were not accepting COVID positive health workers on the society. After that, quarantine period was reduced to 7 days, and through coming up to the third floor, there is no provision of quarantine facility to the staff working on the COVID. During the first floor, the announcement of 100% incentive and basic salary to frontliners was announced by the government of Nepal. And in the second floor, it was reduced to 50%. And in the third floor, there is no any provision of any health hazard incentives. But to date, We had got very few incentives that was so low, which was announced by the government of Nepal. While talking about the challenges faced by hospital management and the workers, during the first flow, there was a lot of fear, anxiety, depression, stress. People were panicking. No one wanted to work on the COVID wards. Assigned staffs in COVID ward had thought as if they were getting punishments. Shortage of sanitizer, masks, and other necessary equipment were also so uh, very frightening. Staff patient ratio was not so appropriate. Even in the respiratory ward, we worked on 1:30 patient ratio, one staff to the 30 patients. No one wanted to work on COVID directly or indirectly. At the period of such panicking situation, there was no any motivational and counseling sessions provided by the hospital to the staffs working in COVID to motivate and increase their self-esteem. During the second flow, challenge was very different. There was shortage of oxygen, oxygen masks, ventilators, ICU beds. Resources were limited regarding oxygen, but we at the hospital, we hardly faced the shortage of oxygen. Globally, everywhere people were facing the shortage of oxygen at that time. Our hospital also cannot be the exception of that. On that scenario, it is difficult to work on the low supplies of oxygen and ICU beds. Besides this, TUTH has managed the patient even on premises of COVID emergency by supplying the oxygen and pillars too. Although there was 2 ICU with 30 beds and many high dependency units, it was not sufficient for the patient. Here in the picture, we can see the premises of COVID emergency where many people are getting oxygen through small pipes and the pillars too. And coming to the third floor, the challenge was very different. Most of the hospital staff got infected. Many wards were merged due to the shortage of human resource. Limited wards were managed for COVID patients. Bed capacity was increased to give more service to the patients. So on the capacity of 30 beds, we provided service to the 40 patients. While talking about the challenges faced by as a woman frontliners, personal protective equipment were limited and unfitted PPE supplies. Here we can see in the picture, there are so many PPEs, N95 masks, surgical masks, hazmat suit, gown, gloves, uh, boots, and shoe cover. There were so many personal protective equipments which were oversized to the female workers who weighs average height and weight. There were very painful years due to double and triple marks. We have to fix the marks on a special kind of bands so that the marks will be tight on chin and our nose because marks were too large for our face. Due to the use of double triple marks, there was poor air ventilation on the face, painful feet by the using hard sole boots, fearing to get COVID infected. We have to use unfitted, oversized PP by fixing it by some rubber bands on our hand and feet. Hazmat suits, gown 95 and surgical masks, boots for female with too large. Here we can see some marks on the face, painful scars on the face caused by the marks on our faces. The food supplies were also unchanged and the taste and packaging for the staff on the COVID ward were so disgusting, for which I skipped the dinner. Long bedside hour was so suffocated and so exertion, excessive sweating. There was no chance for bowel and bladder movement, no food at the time of hunger, and even water during thirst, which caused dehydration with the PP. As a woman frontliner during the menstrual cycle, we have to work actively even with cramps, dysmenorrhea, and heavy bleeding as a consequence of a stressful condition and no chance to get change pads timely. While talking about the personal hygiene and its effect, daily bath at late evening with long hair troubled many more times. After the exhausted duty schedule, we had to return home at the late evening. And at that time, each day bathing with long hair caused many times common cold for me as well as to my friends also. For this, we had to test out. We have to give the sample of PCR unnecessarily for many times. For that, I chopped my hair too. While returning at the home at late evening after 12 hours shift during lockdown, I was so terrified and I feared to be sexually violated and theft at the time. During the period of isolation days, as the hospital has provided us hospital quarantine, there was separation anxiety from family. I had missed my homemade hygienic food, loneliness and isolated from room of hotel quarantine, restriction to mobility were so irritating. Right the moment I regretted to be a frontliner. Here in picture, I had captured a screenshot of my daughter and my husband where I was in hotel quarantine and my husband and daughter was in a home. Sorry. At that time, I had also known that COVID, at first phase, COVID was so scary. People were thinking that after getting infected, many people will die. But up to coming to the situation after handling the COVID virus, we came to know that every infected people will not die. So at that time, we were expecting that if we got COVID infected, then we will get quarantine, which will be our good break because at that time, adjusted duty schedule and there was no any provision of leave for the staff except quarantine, and later on the quarantine was also reduced. So why I am a PhD scholar and a nursing as professional and a mother of three year baby girl too. This became a very challenging situation for me to balance my work and family. During this period, there was lots of stress, anxiety. I was depressed too. My parents with diabetic and hypertensive in my family got feared, afraid, and doubted that frontliner as I will transfer the virus to the hospital to home. I get separated from my family and stayed alone for 2 weeks on my rented flat when first case was seen in the hospital on the May 2020. My dad did not wanted to mix me with the family as I will transfer the virus. So he kept it me on the rented room. After that, I confessed with my dad and mixed with the family with strict precaution. Again, my dad isolated for me when positive case was seen in my neighbor ward on August because the cases were increasing day by day and in non-COVID wards also many patients were tested for positive. After isolation for 1 week on a rented room, my ward too became the COVID ward and I shifted to the hospital accommodation on 19th August 2020. But at the time when I was in isolation, beside being a positive, my house owner had a very good understanding. They were very appreciating and they used to call me with mix with them, and they also used to uh, call me and sit on their balcony. At that time, the my family had ignored me, but the house owner had accepted me and they mixed with me during the isolation period. The fear of misleading perception of the transmission of the virus from only frontliners break in my family when my sister-in-law tested positive for the COVID first and subsequently to mom, my dad, brother, and his 22-month-old daughter, except for my 3 years baby on the September. Luckily, till date, my child is not tested positive. It is hard to change the community's fear of virus. My husband was so supportive and caring, but he was out of Bali at the time due to his working station was in Tanau district, and my daughter was with my family. I was unable to concentrate on my studies for many months. I cannot work on my PhD proposal. When I shifted to the hospital accommodation during the COVID, working in the COVID wards, people from my community thought that I was tested positive and I was hospitalized. They related my profession and blamed my family as the house of COVID, and my 3-year-old daughter was excluded from outdoor playing, saying that her mother is a nurse and she will transmit COVID on the time of September. Being a frontline was a social stigma to transfer the virus. Some decades ago, there was a social stigma on nurses due to of shift duty, especially duty of night shift. People from patriarchal societies had questioned on their character. After facing the challenge of stigmatization, now new generation are facing the challenge to be socially excluded. Due to the COVID duty and hospital quarantine, I missed joining the Dasai festival of 2020 with my family. Even I was not there for my baby's birthday celebration. Even at the same time, I have lost my 4 nearest family members due to COVID. During the period of this situation, I was so physically and emotionally drained due to my COVID duty and husband out of my home. My daughter's online classes were interrupted. My presence and support for my daughter's online class and homework were also interrupted. My daughter's birthday is on 25th October. Here we can see my mother, my sister-in-law, and her daughter are celebrating my daughter's birthday. And in second picture, my daughter is doing her homework. Now discussing about a COVID case where my mind is stopped in 16th May 2021. I was totally emotionally drained at that time. I was unable to focus on everything. It was challenging for me to balance my work, family, my study, my child, everything. During the second flow of COVID, the hospital was suffering from a shortage of oxygen masks, ventilators, ICU beds, for which the hospital had made circular to lower down the oxygen flow. People were not getting ICU beds. Even the young patients had to be on prone position to increase their saturation on general beds. The situation was so scary. People were getting ICU beds on recommendation rather than on priority basis. It was so unfair to get a consent of do not resuscitate DNR form by visitors of young patients who might get life if I had got ICU beds and ventilators on time. Or 21 at the 16th May 2021, when I was on night shift, a 21-year young postnatal mother on the 10th day of delivery date on my night shift has found with a saturation was below 60% and was struggling for oxygen. Overnight, she struggled, but at a morning 5 a.m., she could not struggle anymore and she died. My eyes rolled down when I was packing her dead body in a bag and called the mortuary. I feel like I am a criminal who had killed a mother of 10 days baby. I regretted if I had increased the flow, she might be alive today, but I was helpless at the time. In the another similar case on my duty hour, the staff of our own hospital from medical ICU, a 27 years cleaner, suddenly collapsed and his death was declared right the moment. These two stories are stuck on my mind and it takes a lot of time to get out of this. While getting infected and quarantine, I globally all many millions of people were getting infected and I cannot be the exception of that. During in 27th July 2021, I was tested positive and my city count was only 17. But I took my quarantine as a holiday, as a break, because at that time we were not getting any leaves, very exhausted duty schedule, too much workload were so suffocating. I took the situation very normally as a break. There was nobody to disturb me, no work, no stress. I enjoyed myself, my pampering myself. I watched movies, followed many skincare and hair care routines. I ordered food from restaurants and enjoyed different varieties of delicious food. I felt my room as a room of a resort for where I was in a vacation. A good greenery view of Nagarjun jungle can be seen from there. So I fully enjoyed my quarantine period when I was tested positive. So after 1 week, when I gave the sample of PCR and it was surprisingly negative. Within 7 days from city count 17, I won the COVID. It was only possible because of my willing power, positive thoughts, and caring family members. Because coming up to this situation, my family had understood the context of COVID and had accepted the health workers that they will not transmit the virus. At last, with learning and hope, I gained many things from the COVID. Pandemic changes all the daily schedules, but help us to tackle unforeseen global health risks and management. At first, I regretted to be a frontliner, but hope but when the coverage and support from national media houses raising both voice of frontliner and issues gave me more positive energy to work on COVID. Now there is no COVID patients and I am currently working at the onco daycare where patients of cancer get chemotherapy. Rigorously, I am engaging on my PhD proposal and weekly workshops organized by Tribhuvan University Grassroots Community TUGC. And at last, I hope that the minimal stuff issues and shortage of oxygen masks, ventilators, ICU beds, surplus medicines, frontliner motivational programs and rewards, security of frontliners shall be addressed soon, and no people from lower income will suffer in the future. Hope vaccination will be easily accessible to the people throughout the country. And finally, this is the image references, and thank you for being a wonderful audience.
Thank you so much, Sadhana. That was really great. So we'll move on to our final presenter, who's K. Kalyani in the Sociology Department of Jawaharlal Nehru University in India, with Unending Social Distancing, Experiences and Resilience of the Dalit Community in India during COVID-19.
Thank you, Kathleen. Am I audible? Yeah. Okay, perfect. Firstly, I would extend my thanks to University of Hawaii, Anna and her team to give me this opportunity to present my paper at this very enriching and engaging conference. So it was really nice listening to the other presenters and the experiences of COVID-19, particularly those who have been at the forefront of as the frontline workers. However, my paper is slightly different, where I have engaged with the whole concept of social distancing and what social distancing means and has meant for Dalit communities during COVID-19. The paper is more centered around discussing the concept of physical and social distancing, and particularly drawing on the questions of purity and impurity that have been faced by the Dalit communities in India. I have done a specific case study of a woman called Sunita Devi. She's from Champawat district of Uttarakhand, and she has been the care worker, and she has been engaged in the process of midday meal preparation. And through her case study, I will actually try to understand what the COVID experiences for Dalit communities has meant in the context of India. So to begin with, I would briefly talk about what my paper is largely about, and then I will go on to the specific case study that I intend to talk about. So COVID-19 has affected population across geographies, irrespective of people's nationality, class, race, caste, causing similar medical symptoms that can potentially affect almost anyone. However, the medical experiences of pandemic was a great social divider that had rendered marginal communities more vulnerable than the affluents. For Dalit communities in India, the COVID-19 experience was another challenge, as the practice of social distancing was followed by the legitimization of untouchability practices that the Dalit community were historically subjected to for centuries. So my paper is drawing on the experiences of care worker Sunita Devi, who had served as the midday meal worker from the Champawat district of Uttarakhand during COVID times. The controversy sparked when the upper caste students refused to eat the food cooked by her, as they considered it defiling their purity. In response, Sunita Devi had her own experience of resilience, and I'll discuss briefly about how she resisted and stood against the kind of purity norms that were imposed on her. And so before I begin my paper, I would briefly like to talk about what this concept of purity and impurity means, particularly in South Asia and in India specifically. So the concept of purity and impurity has been discussed by a scholar like Liu Dumont in his work Homo Hierarchicus, where he has talked about where he has talked about what constitutes pure and what constitutes impure, and this dichotomous relationship between purity and impurity is largely centered around the notions of caste and the way Hindu society has unfolded the caste structures. So before going into the specificities of what impurity and purity means in a caste-ridden society, let me briefly talk about how caste structure unfolds itself and what are the norms through which caste operates in the society. So here I would like to talk about the works of G.S. Kure, who is one of the renowned sociologists, and he had identified 6 features of the Hindu caste system. And it is in these features of the Hindu caste system that there has been an exclusion faced by the scheduled caste and the lower caste communities. So the first feature that Gure talks about is that the Hindu caste society is a segmental division of society. Caste groups are well-developed networks, and somewhere the membership of each caste group is not determined by the choice, but by the birth. The status of a person depends not on the amount of wealth or education that person has, but is very much innately inbuilt in the caste he or she belongs to. The second important thing that Gure talks about by talking about the structures of caste system in India is that it is a hierarchical system, and there is a very strong and a very stringent caste hierarchy that is in the making of the caste system in India. And to relate this point, I would like to also relate this point to what Dr. Ambedkar has said, that a caste system is like a building with with no walls, with no doors and windows, which means once you belong to a caste, you are ascribed to that identity and you can't move above or below it. So that way, the hierarchy in the caste system is an ascribed status, and one cannot escape the caste experiences and one's belongingness to a particular caste. The other feature that defines the caste system in India is that there is a restriction of feeding and the way one does the social intercourse. So it is through the caste system that one actually comes to know whom to dine with and whom not to dine with, what sort of food one has to eat, and what sort of food one is prohibited to eat. So there is a restriction on the feeding habits as well as the social interaction, and much of these are defined through the caste norms that prevails in the society. The other important feature of the caste system is that it brings a civil, and this is one of the very important thing that I think is that it brings religious as well as civil disabilities to certain communities in the society, while it privileges certain other communities in the society. So caste system actually segregates an individual caste from many others, where some castes are privileged to do certain kinds of work, while certain other castes are completely denied from the works and the process of education. So that way, again, this is a reflection of the kind of hierarchy that the caste system entails. The other important thing that Gure has mentioned when he talks about the caste system is that there is a lack of choices when it comes to employment. So once one belonged to a particular caste, yeah, the choices of occupation becomes limited, and it's largely centered on one's caste identity. So one can say that in modern institutions or in a modern society, these restrictions of occupation might have been overcome. But somewhere in practice, when we look into the way the scheduled caste or the low caste communities occupy the occupations, they have been largely reduced to the menial task, and to tasks which have been defiling and have been traditionally given to them. So that way, there is a restriction of occupation when it comes to the caste identities. And lastly, one of the most important feature of caste practices is the practice of marriage, where caste system talks about an endogamous marriage relationship, and one is denied to marry outside one's caste structure. So I briefly tried to bring these structures and the features of caste system, because somewhere when I was looking into what caused the exclusion of Sunita Devi during COVID times, it was not just because of the COVID experiences, but also because she belonged to a scheduled caste community and was historically marginalized and historically socially distanced to those to the practices of social distancing. So to come to again this whole concept of purity and pollution, and I discuss this concept of purity and pollution precisely because Sunita Devi was denied the access to cook, because the upper caste felt that once she cooks, she'll be able to touch the food, and touching is considered as an impure act. So the whole act of impurity, I would like to say here, is not an act of hygiene or an act of just physically touching the food, but it is deeply embedded again in the caste structure, where once one touches the food, it is considered defiling according to the prescriptions of the Hindu social order. So coming to Louis Dumont again, where he has extensively talked about what these concept of purity or what these structures of purity and pollution implies, he has actually said that the practice of untouchability is not about just a physical hygiene, but it actually implies the caste of mind that is prevalent within the society. And so what makes an untouchable impure is because he is supposed to distance himself from a pure Brahmin. So there is the whole notion of segregation of work, occupation, the whole notion of endogamy actually emanates from the caste structure of purity and pollution, where the very proximity of an untouchable community is considered as defiling and considered as not acceptable within the society. And it is in this context I would like to discuss the case of Sunita Devi, who was the Dalit cook from the Champawat district. So Sunita Devi, she belonged to she's an educated woman. She did her schooling, and she belonged to the district of Champawat in Sukhidang area of Uttarakhand. She was employed as the government. She was employed as a cook at the government inter-college, where she was to cook for some 43 students of the school, and many of these students also belonged to the upper caste community. The cohort of the school in the cohort in which of the school in which she was to cook was basically starting from classes 6th to standard 8th, and the whole issue sparked amidst the COVID times, when the upper caste student actually denied the acceptance to eat the food that was cooked by her. In fact, in some of the reports that came up, she also mentioned that when she was involved in the process of cooking, there was casteist remarks and slurs that were imposed on her. Uh, the whole issue sparked up, and there were discussions and debates around it. But the official actually, the government officials and the school administration actually sidelined from the whole issue, saying that the lady Sunita Devi was not she was not the right candidate for the position of cook, as she had skipped some of the procedures that were required for her to become a cook. However, later investigation found that these were just the excuses that the government officials were making. And in fact, it was whole casteist and it was a whole casteist worldview and the whole casteist setup that has actually excluded excluded the Dalit cook from becoming part of the midday meal worker. It's interesting to know that it's not for the first time that there have been exclusions of the Dalit community in midday meals. There have been cases where the Dalit children are they have been excluded within the education system. They are not allowed to touch the water in the school premises. Even when it comes to their education, they are made to sit at a distance. So there's a whole and even when it comes to midday meal access for the Dalit students, they are many a times denied the midday meal completely because of their caste status, and because the dominant and the upper caste don't want them to come within the educational spaces at the first place. So but this case of Sunita Devi was specifically interesting because the whole when here we are talking about this whole notion and this whole dimension of COVID-19 and the whole concept around social distancing, we also need to understand that the whole aspect of social distancing has been there, historically been there as a caste experience for Dalit communities, and the marginalization of the Dalit women during COVID-19 was even more because firstly, they were historically denied the access, and during COVID-19, there was some kind of a sanction that came up through the health institutions to actually confirm these historical denials. So that was briefly the case of Sunita Devi I wanted to talk about. Do I have time, Anna?
So you have about 5 minutes left, but since we still have a good hour left, Dr. Stir, or do you want to take time or?
Well,
So yeah,
we'll have lots of time to discuss, and I want to make sure that everybody else has time to get their questions answered so we can have a very good discussion. So please continue with your 5 minutes. It's okay if you go a little bit over, but remember that we're keeping time for discussion. So yeah, thank you.
Okay, thank you, Anna Crispin. So I'll briefly now talk about the COVID-19 experiences for Dalit community in general, where now I would like to briefly discuss how the experiences for the marginalized community during COVID-19 were. So like many other South Asian countries that we discussed, in India, the spread of COVID-19 was also very bad, and but what was interesting here to look into that the spread of the pandemic actually percolated deep down to the social stratifications and the caste structures that were prevailing within the society. So in this context, it's also interesting to look into the works of Susan Sontag, where she had discussed that when AIDS became a global pandemic, the deaths during AIDS were, of course, I mean, the death due to AIDS were not far from being even. But what also added to the illness beyond medical terms was that there was a lot of stigma that floated around the communities who were more vulnerable. So something similar happened during the COVID-19, where when it came to the experiences of the pandemic, it was the vulnerable sections, and it was the Dalits and the low caste sections who were who became less privileged. Firstly, to access the medical, the medical resources, as Sadhana was also mentioning, but they were also marginalized because of their economic situation, and also because of their caste relationship within the social structure. So it's also interesting to see that once there has been a common saying around this pandemic that pandemic has been a social equalizer. So anybody can get affected with the virus, and everybody has equal chance to get infected. However, this is far from reality, because firstly, of course, there has been a differential way in which medical access has been accessible to the communities across, and also secondly, there have been groups who are more privileged, and they have actually been actually able to capitalize from the pandemic like situations. So for example, if in the context of India, in the same North India, if I look into, there were so many temples and religious places that started online pujas, and they started online prasad distribution, and online stuffs, because and they were able to do so because they were in that privileged position to access resources. Something that was, and this was something that was not accessible to the marginalized communities. So that's my brief discussion, and I'm open to the questions. Thank you.